Thank you. It's really nice to be asked to come and talk at the symposium, so I'd like to start by thanking the organisers. When I was first contacted about this, it was in relation to a paper I published a few years ago, which is the first part of the title. But actually, that's several years ago, and I thought it would be much more interesting to talk about some of the advances in the field that have happened since publication then. So my corrected title really is Exercise, Muscle, Cirrhosis and Liver Transplantation in 2016. I'd also just like to state that I'm extremely proud to be standing in front of a European Union flag. Okay.
Maybe we could take a picture.
Yeah. So this is where I work. I'm a specialist intensive care consultant. I'm a physician intensivist. I work in a 19-bedded liver intensive care unit at King's College Hospital in London. Each year we admit about 1,400 patients with liver disease. About 350 of those have got chronic liver disease and complications. And we admit between 150 and 200 patients after liver transplantation. So I'm very much in my comfort zone looking after people like this. This is a young woman with acute liver failure, multi-organ failure, who we successfully transplanted and who left to go home and is doing very well. So I'm comfortable looking after patients like this. But periodically I'll get contacted from the junior doctors on the ordinary ward to go and see people on the ordinary wards. And that's when I start moving out of my comfort zone, or at least it was. So I would get a call from one of the junior doctors who's running transplant assessment who would say, could you see a patient undergoing transplant assessment? He's 54 years old, he's cryptogenic cirrhosis with a MELD of 20, he's a non-smoker, is non-diabetic and has no cardiac history. His echocardiogram looks okay, but his sodium is 129, he's malnourished and has been hospitalised, mostly bedbound for much of the last 4 months. And the difficult, if not impossible, question that then follows, of course, is he fit for transplantation? So I'm confronted by this question. So I have to go to the bedside and try and start to make an assessment of this patient's fitness for transplantation. So some of the more straightforward things to look at are the severity of his liver disease. I can actually have a series of scoring systems which help me to do this. I can then look at the effects of specific comorbidities, such as heart disease, diabetes, renal dysfunction, and so on, which will impact upon waitlist and post-transplant outcomes. But the more difficult things that we have to assess are the effects of the general decline in condition that we see in these patients with chronic liver disease. So what we see in terms of nutritional and functional status, which all contribute to a general state of frailty and impaired global health status. So those are the challenging things that are much more difficult to assess. So what we have to do is go to the bedside where the patient's sitting on the ordinary ward and perform what's an eyeball test, a subjective assessment of all these factors. So what I propose to talk to you over the next 20-25 minutes or so is a simple clinician's perspective. I should say I'm not an exercise physiologist, I'm a simple clinician, about how I see things in relation between functional status and mortality in patients with chronic liver disease, both, as I'll show you, in the transplant and non-transplant setting. How we can support objective assessment of patients' fitness in the eyeball test, looking either at aerobic capacity or the presence of muscle loss and weakness and sarcopenia, and then some very new data on specific interventions. We've now got some drug trial data very recently released, and I've summarised what we know about exercise therapy in this situation. So I'm assuming that many of you won't know that much about chronic liver disease and its clinical course. So just to summarise, we have patients who've got cirrhosis but are well compensated. They haven't got ascites or overt encephalopathy. Each year, about 10% of these patients will then progress to a decompensated state, and these complications will be present. And part of the art of what we have to do is we have to use our medical and other therapies to return them to a compensated state, and then some of them, of course, will then go back round through the cycle. And the next art of being a hepatologist is we have to identify those patients whose survival outcomes will actually be favoured by transplantation. So we can get them waitlisted and get them successfully transplanted. And actually, if we transplant somebody these days, mortality is actually very low. Very few of the patients who we transplant successfully, particularly first transplants, will die. So death after transplant, certainly in our series of first elective transplants, is less than 5% at 1 year. The bigger challenge is getting somebody through to transplantation. With the increasing scarcity of grafts, our patients have to wait quite a long time. And currently our 1-year mortality on the wait list is between 10 and 20%. So by far the bigger challenge is actually getting people through successfully to transplantation. And in part, that's because throughout this process, these patients are deteriorating. They're becoming increasingly frail, their nutritional state is worsening, they're losing muscles, they're becoming sarcopenic, and they're generally deteriorating. So just to slightly divert, because I'm going to use this terminology elsewhere in this presentation, many of you may or may not be, may be unfamiliar with the Model for End-Stage Liver Disease, or MELD score. This is the shorthand that we use to categorise the severity of chronic liver disease. And effectively what we do is we take the serum creatinine, bilirubin and INR, which is a measure of coagulation, we log transform it, we weight it, and then we generate a summary score, multiply it by 10, round it to the nearest whole number. Sounds a bit complex. But we get a score between 0 and 40, and this is widely validated as being very predictive of 3-month mortality without transplantation. And it forms the basis of transplantation listing in many series, including the US. So this is your MELD score and the relationship with non-transplanted mortality. And you can see that with increasing MELD score, 3-month mortality progressively increases. And we take a MELD score of around 15 as being our minimal criteria for waitlisting somebody with chronic liver disease. So there's a clear relationship between your MELD score and non-transplanted mortality. But actually the relationship between MELD score and determined immediately preoperatively an outcome after transplantation is much less straightforward. These are data from a large UK study looking at pre-transplant MELD score, and you can see you only really start to see a detrimental effect if you measure liver disease severity using this scoring system when you get to the really extreme scores. So it's not straightforward. What we are, however, becoming increasingly aware of is that there is a big impact on patients' functional status prior to transplantation. There are a number of studies that have looked at this. They're mostly recent ones, but this is one of the larger, slightly older studies which looked at nearly 4,000 liver transplant recipients and then looked at their performance status immediately prior to transplantation. And what they found is that 90-day mortality progressively fell as functional and performance status fell. So whereas you'll see a 5.3% 90-day mortality in those patients who've got no restriction to performance, in those who are completely reliant on nursing care, this rises to around 25%. And interesting, if you then look at patients who are not transplanted, a similar relationship holds. These are more recent data from the US, looking at 700 plus admissions to hospital of patients with chronic liver disease, using a simple nursing assessment of activities of daily living. And these authors found that there was a clear and highly significant association with increasing dependency, increasing loss of independence, and 90-day mortality. So it's important in both the transplanted and non-transplant settings. But it's not simply a point assessment of functional impairment that's important here, and we saw this data touched upon earlier on. It's how your function declines, it's how things change dynamically. And these are data from a very, very recent publication from the US where they had more than 300 waitlisted liver transplant candidates with chronic liver disease and did 3 monthly performance status assessments on these patients. And these included hand grip, gait speed, chair stand, SPBB and so on. And what these authors found is that the rates of deterioration in all these measures showed significant variation when the different groups of patients were concerned. So those patients who died on the wait list deteriorated much, much more quickly than those patients who were successfully transplanted or those who were still waiting to be transplanted alive at the end of the study period. And this held for a whole series of different assessments and remained significant, highly statistically significant on multivariate analysis. So just to summarise the first section, functional status and mortality in chronic liver disease actually is about 2 sorts of mortality, both after surgery, which is uncommon, and more commonly on the wait list, that we see differential impacts from different factors. Liver failure and specific comorbidities alter things differently, but actually functional status and frailty appears to have a much broader impact. It may well be independent of the severity of liver disease, depending on how you measure it, and the dynamics of the deterioration are important. And actually, I think importantly, it's not actually included in the current prognostic measures that we use to prioritise patients for transplantation. So what objective measures can we use to support the eyeball test that we use to assess the patient in this bed? Well, cardiopulmonary exercise testing is something that one would reach for first of all as an anaesthetist. I would think many people in this room know far more about this than I do. What we're principally interested in here are measures of aerobic capacity. I think you've seen this flowchart already, coupling pulmonary ventilation to mitochondrial and muscle respiration. And as you can see, looking at the different complications that you see in patients with chronic liver disease, it would not be any surprise if aerobic capacity was impaired in patients with chronic liver disease. And indeed, this does actually appear to be the case. There are a number of studies that have looked at this. This is data from a French study of 135 patients undergoing liver transplant assessment, and these authors found that impairment of aerobic capacity was both common and severe. More than 85% of the patients they looked at had an impaired peak VO2. More than half of the patients they looked at had a peak VO2 that was less than 60% predicted and they felt was functionally significant. But importantly, fewer than 5% actually had an echocardiographic ejection fraction of less than 60%. So this simply wasn't just cardiac insufficiency. And interestingly here, they measured the severity of their liver disease in a slightly different way using the Child-Pugh classification where C equals the worst sorts of disease. And actually, they found a relationship between liver disease severity and impairment of VO2 max. But how does this impact upon survival? Well, this provocative study came from Newcastle, published a few years ago, Newcastle in the UK, where they looked at a series of 180 plus transplant assessment cases, of whom during their study period 60 were transplanted and 6 of these patients died within 100 days of transplant. Actually a relatively high proportion. But what they found is if they compared survivors and non-survivors of transplantation, there was a highly significant difference in the anaerobic threshold, another measure of aerobic capacity when they compared the two groups. And actually on their multivariate analysis, this was the sole predictor of post-transplant mortality. So this stirred up a lot of interest in this sort of assessment. So we took this a little further forward and looked at our series. We'd been performing cardiopulmonary exercise testing for several years. We had a series of getting on for 400 patients who'd had a transplant assessment that included CPET, but as well as this, we'd also done a dietetic assessment, anthropometry, and CT cross-sectional scanning, which I'll show you is also interesting. And there are a lot of follow-ups, findings from this study which are of interest, but I won't have time to show you now. But we followed them up for nearly 2 years, during which time more than 200 underwent transplant with about 5% mortality. And 176 weren't transplanted, the mortality in this group, because it included those patients who were also too sick to be listed, was actually high at 35%. So these are some of the data that we got for the patients split by gender, and what we found, unsurprising but fairly striking, is the impairment of aerobic capacity in groups, particularly, and I'll show you a bit later on, importantly in men, where more than the median predicted VO2 peak was less than 50% predicted. So these patients had impaired aerobic capacity. But if one compared the survivors and non-survivors of transplantation, we actually found that there was no significant difference at 90 days in anaerobic threshold, in part because we had so few non-survivors at this point. But actually, if we looked a bit later on, at a year, when the number of patients who died actually increased, this difference reached significance, albeit relatively weak, and it remained weakly predictive, weakly independent on a multivariate analysis. What, however, was much more striking is if we compared the survivors and non-survivors who didn't undergo transplantation. So we had 100 and 155 here, where there were very marked differences in aerobic capacity between the two groups, and this remains strongly statistically significant on multivariate analysis. So to summarise the second portion, I think we have relatively limited data in chronic liver disease, but impairment does appear common. It's not quite clear how this relates to the severity of liver disease. I think in part it depends upon how you measure it. There is, however, a reasonable link to mortality, particularly in the non-transplant setting, but the infrequency of post-transplant deaths now makes it more difficult to assess. I guess two questions that follow on from this is, are there simpler tests that we can do apart from exercise testing that will give us at least some of the information, particularly as a screening test? And if we identify people in this way, does this represent a modifiable risk factor? So in relation to the first question, yes, I think there are some more straightforward tests that we can do. These are a couple of studies that have subsequently appeared which have just looked at 6-minute walk distance, both of which, interestingly, have come up with the same threshold, a 250-metre threshold, identify patients who are going to do very badly on the transplant wait list. And in fact, if you can walk less than 250 metres, 80% of the chances patients will be dead within a year. And similarly, we've found some other interesting data which is as yet unpublished, which suggests hand grip may be similarly useful. But I'm also a fan of investigating and using reanalysis of data that we could collect routinely for other purposes. Pretty much everybody who has a liver transplant assessment also has a CT scan, and actually we can use automated software to look at the CT scans in other ways, particularly in relation to determining muscle bulk. There are a number of studies that have looked at this that I'll touch on now. There are a whole series of factors that can contribute to an increased loss of muscle in patients with chronic liver disease, and when they do have muscle, it may work less well. And we can do analysis of these CT scans in a number of ways. This is data from one of the leading groups in the field who come from Edmonton in Canada. And rather than just simply looking at the muscle area, what you can do is calculate a skeletal muscle index that adjusts for stature and for gender, and then compare it to population norms and classify people as being sarcopenic or not. So this is a patient with, so red is muscle, yellow is visceral fat, green is fat within the muscle, and the teal colour is subcutaneous fat, and you can see this is a sarcopenic patient analysed in this way. And actually, using this sort of analysis, this group have found between 40 and 50% of their patients with chronic liver disease have actually got sarcopenia. Interestingly, it's much more common in men, probably 3 times as common in men as it is in women, and it correlates only weakly with the MELD score. But importantly, it's very closely related to survival. These are data from the same series, same group rather, larger numbers, nearly half the patients they found to be sarcopenic, and they have a markedly impaired survival experience without transplantation. So around 50 to 60% of the patients, 50 to 60% of the patients will be dead within a year if they're sarcopenic. Interestingly, there's no similar impact on post-transplant survival. This is the same cohort. What you do see in patients who are sarcopenic is that they have a markedly prolonged length of stay and much more sepsis. Okay, so you've identified a patient as being sarcopenic in this way. What sort of things can you do? I think pretty much every centre who identifies a malnourished patient through whatever mechanism or technique will target them for dietary approaches and interventions to correct dietary insufficiency and to address malabsorption. But there are a number of studies now that have also looked at the potential for addressing androgen deficiency and potentially exercise interventions in this setting. Testosterone deficiency is extremely common in men with chronic liver disease. Some studies have suggested that it's present in up to 90% of men with cirrhosis. It's got a very complex pathophysiology, but the liver is at the absolute centre of the metabolism of corticosteroids and androgenic hormones. And you see a particular phenotype in these patients, part of which includes severe fatigue and muscle wasting. And there have been a number of studies that have looked at intervening with testosterone supplementation, but these are pretty historic and would regard the design as being pretty poor. The study, however, is actually in press in Journal of Hepatology, was presented at the liver meeting in April of this year in Barcelona from Melbourne in Australia. And I'm grateful to Marie Sinclair for these slides. She performed a randomised controlled trial in 101 men with cirrhosis and testosterone that was low, and randomised them either to get intramuscular testosterone or placebo for 12 months, doing DEXA scan to look at body composition, with their primary outcome being appendicular lean mass, with secondary outcomes that included a number of other measures of body composition. And she had a pretty well-matched group, pretty sick, MELD scores in the 13 to 15 range, and in fact 20% of the patients died during the year of the study. But what she found was that if you were given testosterone and if you're testosterone deficient, is that there was a significant increase in APLM, probably at a clinically significant level as well. And when she looked at her secondary outcome measures, there was a clinically significant increase in total body lean mass, that was paralleled by a reduction in fat mass. And there was even a signal towards an improvement in survival. Promising, I think, but clearly will need to be reproduced elsewhere. What about exercise interventions? Well, astonishingly really, given the importance of the physical deterioration that we see in these patients, I think these summarise pretty much all the studies that we've seen in the last 15 years of exercise interventions in patients with chronic liver disease, and a total of 80 patients, relatively sick. I think there are a number of things that one can surmise from these things. Even though these patients have got relatively advanced chronic liver disease, actually they were very well tolerated, that we saw improvements in aerobic capacity and in measures of exercise capacity, where looked for body composition changed in a favourable direction and quality of life improved. So again, very, very promising, and I'm astonished that things haven't been taken further with these patients. Of course, the most effective intervention that you have for these patients is to undergo liver transplantation, and there are very few studies that have actually looked sequentially to see how this changes exercise capacity. This is one that I could find from Denmark, 23 patients relatively early, doing sequential pre- and post-transplant exercise assessments. And what these authors found is that over the course of a year from transplantation, there was about a 30% increase in measures of aerobic capacity following transplantation. But even so, at the end of a year, the patients were still 10 to 20% behind equivalent matched well patients. So they made some improvement, but weren't quite normal yet. But I think that's an important point to the fact that actually our requirement for exercise support and observation is not finished when the patient's undergone transplantation. This is pretty terrifying data from the US, from Illinois, where they looked at 200 patients with, who'd undergone liver transplantation, but caught them at a mean of 54 months after transplantation. And what they found was that nearly 60% of the patients had evidence of metabolic syndrome. More than half actually did no dedicated physical exercise whatsoever, and fewer than a quarter performed dedicated exercise of 150 minutes a week or more. But what they did also find strikingly is that the number of components of the metabolic syndrome that these patients displayed were closely related to the intensity of exercise that the transplant recipients undertook. Okay, well, I'm going to close there. Just to summarise, what do we know about exercise, muscle, cirrhosis and liver transplantation now? I think we can say that frailty and functional compromise is extremely common in patients awaiting liver transplantation. Part of this, it's a multidimensional problem, but part of this is an impairment of aerobic capacity in the presence of sarcopenia. But we know that there's now a close association with non-transplanted survival, which may be independent of some of the measures of liver disease severity that we have. But we do have a wide range of assessment methods available, and actually finding out which are the best ones to use here it needs to be taken further. And we do have interventions available which are promising, but again need further testing. And I think it's absolutely clear that we have an additional need for other post-transplant interventions. And with that, I'll close, and I'll thank you for your attention.